Welcome to the OMM Medicine's module on anteriorly and posteriorly rotated innominates. So there are four major categories of pelvic dysfunctions, the anteriorly and posteriorly rotated innominates, both of which will be discussed in this module. And there are also the upslip and downslip dysfunctions, which are covered in another module. So let's start our discussion with the anteriorly rotated innominates, and this is going to occur when the innominate on the side of the positive standing flexion test has rotated forward or anteriorly. And so as always, let's talk about the axis of motion first. And for the anteriorly rotated innominates, the rotation motion will occur around the inferior transverse axis of the sacrum. The classic cause for an anteriorly rotated innominate is tight quadriceps muscles, and hopefully after we discuss the palpatory findings for an anteriorly rotated innominate on the next slide, it would make sense that having tight quads could actually pull the anterior aspect of the innominate inferiorly, and that would cause the posterior aspect of the innominate to rotate superiorly, which would cause the palpation findings that you see in an anteriorly rotated innominate. And a common way that this is tested is the question stem will describe the palpatory findings that we will discuss next for an anteriorly rotated innominate and ask you which muscle would you expect to be tight or which muscle should be treated, and it would be one of the quadriceps muscles for the anteriorly rotated innominate because tight quads can cause this dysfunction. And so it's important that you not only know that the quadriceps are associated with an anteriorly rotated innominate, but you also need to remember the four major muscles that make up the quadriceps. And as you will see for most of the pelvic dysfunctions, the way that we diagnose it will be similar. You'll start with the standing flexion test, palpate the ASIS, and also palpate the PSIS. And you can also do the in-flare, out-flare palpation to see if the patient has that, but that is not necessarily required to diagnose an anteriorly rotated innominate alone. So now let's look at what an anteriorly rotated innominate would look like for both the right and left sides. So for a right anteriorly rotated innominate, we are going to start with the standing flexion test, and in this case it will be positive on the right. And you could also do the ASIS compression test. That's also sometimes listed in test questions, and again, that would also be positive on the right. And now we will go through and palpate the ASIS and then the PSIS. And so the ASIS is going to be inferior on the right. It's going to be more towards the feet. And the PSIS on the right is going to be superior, or it's going to be more towards the head. And again, remember that the opposite side findings will be the exact opposite of that. So the ASIS will be superior on the left, and the PSIS will be inferior on the left. And this is all relative to the side of the positive standing flexion test. And the exact opposite is true for an anteriorly rotated innominate on the left side. So here we would have a positive standing flexion test on the left. The ASIS compression test would also be positive on the left. The ASIS would be inferior on the left, and the PSIS would be superior on the left. And the exact opposite findings for the right-sided ASIS and PSIS would also be true. So let's start with some relevant anatomy first, and just for orientation, we are looking at the right innominate from the posterior aspect. And so this right here would be your PSIS, and if we were to rotate it to look at the anterior surface, this would be your ASIS here. And those are the two major structures that we're going to look at for the OMM component. So let's start with an anteriorly rotated innominate on the right, and just for orientation, we are looking at the innominates from an anterior perspective. And so for an anteriorly rotated innominate on the right, the motion will look like this. And so you can tell that the ASIS on the right is now inferior relative to the one on the left. And the PSIS on the right is superior relative to the one on the left. Let's look at what an anteriorly rotated innominate on the left would look like now, and it would look something like this. And once again, notice that when the motion occurs, the ASIS on the left side is going to be inferior than the ASIS on the right. And the PSIS on the left side will be superior relative to the PSIS on the right. And hopefully it makes a little bit more sense now why tight quadriceps muscles will cause an anteriorly rotated innominate. And remember that most of the quad muscles are going to attach somewhere on the ilium, whether that's the ASIS or the AIIS. And so what happens is that they're going to attach here, and then when they become tight, they are going to contract and shorten, and that's going to pull the innominate bone anteriorly, causing an anteriorly rotated innominate. So how would we treat an anteriorly rotated innominate? Well, you're going to have the patient lay supine and you're going to stand on the side of the dysfunction. So if it was a right-sided issue, you would stand on the right side. And you're basically going to push the patient's knee against their chest and have them resist this motion, have them push against you. And you're going to do this for 3 to 5 seconds, take up the new barrier, and then repeat. And obviously, as always with OMM, we are going to recheck the dysfunction. Now let's go ahead and talk about posteriorly rotated innominates, and these are the exact opposite of the anteriorly rotated innominates. But as always, let's start with the axis that motion will occur around, and the axis is